Hi, I would like to start this pharmacokinetics tutorials once again. I believe that this series have helped you to understand the topics clearly and a firm pharmacokinetics base. This is the seventh part of the tutorial, and here we will focus on the multiple dose administration pharmacokinetics, especially with intravenous part. And you can check the basics of the pharmacokinetics in the earlier part of the series for a better understanding. So let's start. There are a lot to know in the world of pharmacokinetics.
So the first figure shows that of a single IV dose, whereas the second figure tells you about the plasma concentration changes after multiple such doses. The basic idea of multiple injection is to attain the steady state plasma concentration. Let's recap about steady state plasma concentration. So steady state is achieved at a time when under a given dosage regime, the mass of drug administered or absorbed is equal to the mass of drug eliminated over a dosing interval. That's very important to remember. So apart from the single compartment, other assumptions for the discussions are as follows. First of all, it should follow linear pharmacokinetics. That is the rate process obeys passive diffusion and first order elimination kinetics. Second is the tissues can take up extremely large amount of drug. Third point is that the apparent volume of distribution, the elimination half-life, and the elimination rate constant are independent of the number of administered doses. Then time interval between dosing or successive doses is constant, as well as the administered dose is equal at each successive time interval. Next, moving to the objectives. Actually, I thought that not to make this presentation lengthy, so I decided to divide the content into two lectures, part A and part B. So in this part, we'll be discussing on the following topics. That is, one is the average steady state plasma concentration, how many doses are required to reach that, and the second is the max and the minimum plasma steady concentration at steady state, and also we'll be discussing on the fluctuation of doses. Some important points that you should remember in this session. The first thing is that you have to know the which one is IV dose pharmacokinetics and another is the oral dose pharmacokinetics. In that case, how can you differentiate? First of all, think that in case of IV doses, it will start directly from some point of concentration at the very beginning. Okay, here also it has started, but again you can see there are some gap between the y-axis as well as from the curve. This is because it takes some time for the drugs to reach the circulation and ultimately to work. Here in this case, the sudden peak it may be because it is a very fast acting molecule. Second thing is that in case of IV pharmacokinetics, there is a sharpness in the curve, but in case of oral dose, it is slightly bent here at the top of the plasma concentration curve that you should understand. So the very first question is why should we know about the multiple dosing pharmacokinetics, or you can say when to start the second dose. Basically, pharmacokinetic accumulation will occur if a significant proportion of one dose is still present at the time when the next dose is due. So let's move to the lower trace dotted line, that is black color. The drug is eliminated rapidly, that is the elimination rate constant is around 0.5 hour here. And by the time the next dose is due, virtually the whole of the initial dose has been eliminated. Here you can see that the concentration, the plasma concentration of the drug of the initial dose has been almost being eliminated. So the second dose simply repeats the pattern seen with the first dose, and it goes on and on. The pharmaconic accumulation will occur if a significant proportion of one dose is still present at the time when the next dose is due. So here you can see the red line. So the point at which the second dose is being started is the concentration of drug from the early dose is still there. So here the second dose concentration plus the previous dose concentration will add up. So in the upper trace, drug elimination is much lower, that is 0.05 per hour, and only a fraction of the initial dose has been eliminated by 8 hours. So the next dose is additional to a large residue still present in the body, and the second peak is much higher than the first. Third peak is still higher, and so on. This is referred to as the pharmacokinetic accumulation, and it goes on and on ultimately it reaches the steady state plasma concentration. So one thing I felt that you should all know about this, the term the average plasma concentration at a steady state. This average concentration is the one desired therapeutically for patients on a regular dosage regime. So we should note that the average was given in quotation marks to simplify it does not carry the usual meaning, that is the arithmetic mean. So it is neither the arithmetic nor the geometric mean of maximum and minimum plasma concentration at infinity. Basically, it is the plasma concentration as steady state, which when multiplied by the dosing interval is equal to the area under the plasma concentration time curve. So next, we talk about the time to reach the steady state plasma concentration. So it depends whether you want to achieve it quickly, or we should go. If we want to achieve it quickly, then we have to go for the loading doses. But if you don't want to do that, but you can go for a continuous maintenance dose. So how to decide what concentration should be the loading dose? Simply, for example, here you can see one d star divided by d, that is loading dose divided by maintenance dose. So if it's like 1.5 times, it's 2 times and 3 times. Okay. So this dotted line here is the minimum concentration for the therapeutic effect. So if we give 2 times, like 1.5 times or 2 times, it doesn't reach the therapeutic effect. But if you give like 3 times of the maintenance dose, it reaches the therapeutic effect, and ultimately you will see some effects in that case. But what we can see is that the moment we give a high loading dose, it's just close to the steady state plasma concentration. Okay, if it's 2 times or 3 times, and maybe 2.5 times, it may reach the steady state plasma concentration, and you can see those effects means therapeutically, and it is very quick in onset. However, it is important to remember that there are other factors that may affect the steady state plasma concentration. So regardless of the route of drug administration, the average plasma concentration at steady state is influenced by the dose administered, how large the dose is, the fraction of the administered dose, the reaches the general circulation, generally for the extravascular dose, that is the bioavailability, and also the systemic clearance of the drug and the Susan drug interval. So these are some of the important factors that may influence the steady state plasma concentration. So till now we have discussed on the steady state plasma concentration. We can see here the drug, which is the SSPC, that is steady state plasma concentration, and we have 2 points here. One is max and another is the mean. So this is the max here, and this is the mean. The concentration above this is toxic and below is the subtherapeutic. That is the this is a toxic concentration and this is the minimum effective concentration. So that we should keep in our mind. So let us take an example here. We will just try to figure out the amount of drug that needed to reach steady state plasma concentration. So we have these parameters. Let's go to the directly to the formula. Steady state plasma concentration is equal to FSD, F for the viability, S for the salt factor, D is the amount of drug, and C is the clearance, and rho is the how the drug is being administered at the span of 24 hours. So we rearrange it, and ultimately we're trying to find the amount of drug that is being given in 24 hours. So we calculated it, and ultimately we found that the total amount is 85.4 milligram, and since it is twice daily, we have to divide it by 2. That is, ultimately we get around 42.7 milligram of the salt. Now, if we make it like 8 hours a day, that is, we have to give it tedious, the total amount will be the same, but the amount that is dosed will be like 28.4 milligram of the salt for every twice daily. Next again, if we give the initial 42.7 TDS, not BD, then in that case, if we calculate the steady state plasma concentration, it comes like 2.25, and it is quite higher as compared to 1.5 milligram per liter. So what I'm trying to mean that if we increase the dose in a span of 24-hour interval, for example, 42.7 milligram TDS rather than 42.7 milligram BT, then the steady state plasma concentration will also increase that to be in that we have to keep that in our mind. So it's not that for a particular drug there is a set steady state plasma concentration. It varies based on the drug dose. Higher the dose in a particular interval, higher the plasma concentration. That is very important. Higher the dose in a particular interval, higher the plasma concentration. So this we have seen that how to calculate the steady state plasma concentration and also how to calculate the drug that is being required to reach the steady state plasma concentration. So there is another formula that is for the steady state concentration, plasma concentration, that is the max one and the mean one, the upper and the lower level. So we have some parameters here, but the more important is that the dosing is like 2 times daily, 120 milligram, that is 120 into 2 is equal to total is 240 milligram, okay, in a span of 24 hours. And the acceptable peak concentration is 19 and the acceptable trough concentration is 2 milligram. So this is the peak, okay, in steady state plasma concentration. So this is 19 and this is 2. So our, if you give a drug that is 2 times daily, the 120 milligram IV, the concentration, the steady state plasma concentration should lie between 2 and 19. So if we calculated this both of them, what you can see is that the CSS max is around 19.8, which is greater than the state figure, that is the 19, and it maybe bring some toxicity to the patient's body. Now, the acceptable peak concentration and the trough concentration remains the same, but we can have changed in that the dosing is now 3 times daily IV bolus. So here again 80 milligram into 3, that is equivalent to 240 milligram. So what I'm saying is that we have not changed the total drug amount that to be given in the span of 24 hours. What we have changed the dosing interval. The previous one is 2 times daily, that is 120 milligram on daily. Now we have giving 3 times daily, okay, 80 milligram. The dose at this interval decreases. So in that case, what we have seen there, the CSS max become 18.76 and it is less than 19 milligram per dl. So which is less than the toxic dose. And again, the CSS mean is like 14.76. So the statement I just want to give from this two example is that again we have to be very much cautious while giving this drug, whether it is 2 times daily, 1 daily, or 3 times daily. The more you divide the dose, the lesser will be the peak concentration. Okay, so that is very important. So there are two graphs, one drug A and drug figure A and figure B. So we need to find which one is better. In that case, MTC refers to minimum toxic concentration, MEC refers to minimum effective concentration. So here you can see this is the steady state plasma concentration, max and mean, and this is the mean. It is far below the minimum effective concentration. So that what it means that at some point of time the drug will be less effective, and this is very much important way if it is an anti-infective drug, okay, especially antibiotics as well as other antiviral, or you can say antifungal also in that case. But in the figure B, what you can see, the steady state plasma concentration lies between MTC and MEC, and this, and also the plasma concentration, minimum plasma concentration is also close to the MEC. It is just above the MEC. So in that case, if a drug that follows this type of that shows this type of PK, that's pharmacokinetics, is better as compared to the drug that shows the figure A PK kinetics. So this is what we have seen, that 2 times daily. It is like within that it is it is above the toxic concentration. Whereas if you give the same dose, same drug, not dose but same drug, that is in a tedious manner, so that the total dose remains same. In that case, it remains within the C max as well as the C min. Okay, plasma concentration steady state max as well as the min. So we have already covered one topic, how dosing, that is once daily, twice daily, or TDS impact the plasma concentration. We'll further discuss another topic on the fluctuation of dose. So the first factor is the half-life of the drug. Okay. Uh, so let's first understand the role of half-life. Half-life, by the time it takes like two half-life, the concentration of drug in plasma reaches 75% of the steady-state plasma concentration. So, and it takes a period of time equivalent to 3 or 4 elimination half-life of the relevant drug to achieve the steady-state plasma concentration. This is 4 is like 94%, and its half-life it becomes like 96, 97%. So what you can see here, by the time of two half-life, that is if the dose is given here, one second dose being given here, and a third dose is given here. So what you can see that it is like TDS. The drug is being given TDS. So please keep this in your mind and till we discuss the next slide. We can see here the time required for steady state plasma concentration is same here as compared to the previous one. Okay, so what we are trying to do is that previously it was given like TDS in the previous slide. Now we are making it BD. Okay, the dose is kept as same. So in that case, the steady state plasma concentration becomes less 4.8 as compared to close to 12 point something. Okay. Next again, if we increase the dose, now you've decreased the dose, total dose, that is from TDS to BD. For example, if we consider it to be like 2 milligram TDS, and that is around close to 6 milligram in a span of 24 hours. Now here in this table, what we can see that it becomes like 4 milligram in a span of 24 hours. Now again, we are increasing the dose now, increasing the dose in the sense that if it is like 2 milligram, now we're giving 6 milligram BD. So in that case, what we can see the plasma concentration at the very beginning, it becomes 15, okay, and after that you keep on adding the dose at the span of its half-life, that is like close to 12 hours. So if we go on adding, so ultimately it reaches a steady state plasma concentration, that is around 14. And again, this is 14 is higher as compared to one that is being used in the previous slide. So what I'm trying to mean to say that if we increase the dose, the steady state plasma concentration will increase. But the time taken to reach the steady state plasma concentration seems to be similar in that case. So next, we're trying to figure out whether always a high dose means given in multiple doses is beneficial. In that case, no, because the problem in high dose is that you can see the here that there is an up and down here. Okay, this is the max, this is the mean, and we have like three doses, 200 milligram in a span of 24 hours, 100 milligram, 12 hourly, 50 milligram, 6 hourly. Everything is, and if we calculate it, is become 200 milligram. Okay. 50 into 4 is equal to 200, 100 milligram into 2 is equal to 200. The problem here is that it shoots up in the toxic dose interval, and also it means the minimum effective dose here. See the thing. So in this time period, the drug will be in the minimum effective dose. And again, as I mentioned earlier, it is not good, especially for antibiotics, antiarrhythmic, which is a life-saving drugs. Otherwise, the time durations taken to reach this steady state plasma concentration is same. So, in this case, if you ask me which drug I would pick, the answer is like 100 milligram 12 hourly. So, it is between the toxic dose and the effective dose. This 50 milligram 6 hourly is also remain the same. But the point is that no one, the patient will, there will be less compliance from the patients. But if you ask someone, ask the patient to take the drug 6 hourly. So we have here two formulations. One is the first releasing formulation and the slow releasing formulation. So in both this case, it meets uh, the minimum effective dose. So I am speaking about the first releasing formulation and suits the maximum tolerated dose, that or the toxic dose. So there is a lot of variability which we don't want to have to fit any disease. You can find a lot of drugs, especially related to analgesic drug, relieve the pain. But in that case, it is designed in such a way that it is first to alleviate the pain, but it doesn't suit above the toxic dose. Hence, it is safe. Other problems of first release tablet or first release dose is that too many doses are required as compared to slow release formulation, that is the extended or sustained release form. So in that case, because considering the patient's compliance, in that case, slow release may be advisable. So one here is first releasing and another is sustained releasing. First releasing, then leaving. For example, in case of headache, you need to get immediate relief. In that case, you want to have a tablet which is really fast acting. And another is a paracetamol sustained release tablets. It means, for example, in certain type of fever, if you use this crossing, there will be sharp decrease in the fever, but ultimately again the fever will be elevated. So in that case, paracetamol sustained release tablet is a very good option in that, so that it will keep sustain the action will be sustained, and ultimately the patient compliance is also will be good because he will not have to gulp a lot of tablets in that case. So these are my references. Please like and share and subscribe my channel if you think the contents are really worthy. Thank you.